right, addressing functional abilities through interprofessional collaboration to reduce hospital, 30-day hospital. Which of the following reasons for 30-day hospital readmission have you seen? And I'd like to get an estimate of what you've seen most frequently. So go ahead. If everybody, can you all see that poll? And click on your answers. We'll give about 30 seconds. Julie, can you see how many have answered?
Yeah, I can. We have about 72, 75% right now. Do you want me to go ahead and wrap it up?
We'll go another 5 seconds. Let's see what everybody picked. Yes, 96%. So preventable, we have seen them. And which of the following reasons? Difficulty with functional mobility or falls, 71%. And that topic is threaded throughout this presentation very thoroughly. Medication is huge at 50%, malnutrition, dehydration, onset of illness, and 18%. Difficulty following through on discharge plans, 61%, that's high. Difficulty with self-care, at least half. Difficulty with cognitive functioning and general failure to thrive. Your experiences are consistent with what we find in the literature. So thank you for replying to that. Okay. So here are the problems. We've got high rates of 30-day readmission for the same condition. And from an insurance perspective, they don't want to have to pay for that high hospital insurance coverage. From a hospital standpoint, there are financial penalties for high readmission rates. And from a patient perspective, we have compromised health, well-being, and quality of life for people who are readmitted. It's very disheartening from a patient perspective to be readmitted to the hospital. So our objectives today are to utilize interprofessional collaboration to support patient engagement in functional activities while still in the hospital. Implement key principles of patient education into hospital care, discharge planning, and follow-up care, and integrate community services and resources into discharge planning. So we'll examine the problems a little bit. There are many articles about hospital readmissions, so I just selected a couple for examples. In this study, they studied older adults and their readmission rates to acute care at the 30-day and 100-day or 180-day mark after discharge. And they found most common were reasons for being readmitted were chest infection, falls, immobility, and stroke. Remember I said that falls and immobility would be threaded throughout. This is the second place that it comes up. And at 180 days, it was falls, immobility, cancer, and chest infection. Here's another study by Casson and colleagues who studied readmission rates after surgical procedures, and they found GI issues, surgical intervention, and failure to thrive or malnutrition were the top 3 reasons for readmission: GI, surgical infection, and failure to thrive. We can, from a practical standpoint, connect those reasons for readmission to functional limitations. So for example, let's look at GI issues. What's causing those GI issues? Could it be related to difficulty with meal preparation or eating the right foods and challenges associated with that? What about surgical infection? Could that be related to wound care or hygiene challenges, not being able to wash themselves thoroughly or keep their body clean? And how about failure to thrive or malnutrition? Again, could that be related to limited mobility, especially needed for eating, drinking, toileting? We'll re-examine those topics as well. all of those functional challenges really do lie under the 4Ms that affect function. And the 4Ms are what we use to target the needs of older adults. So it's what matters. So the meaningful activities, those are things that are needed to do, such as hygiene, or wanted to do, such as leisure. But what matters the most to the patient? Mobility issue, this is the third time mobility is already coming up. Huge area. Medication, a lot of you answered the poll that medication problems were very common for hospital readmission. And then there's mentation, that's cognitive challenges or emotional challenges, the psychological factors that directly affect functional abilities and can contribute to hospital readmission rates. So let's look at some typical real life examples that contribute to readmission that are related to functional abilities. They're all interconnected. So for example, if a person has limited mobility, this can lead to dehydration and cognitive impairment and a fall, because difficulty with limited mobility makes it hard for them to go to the bathroom. So if they can't go to the bathroom, they avoid drinking water. If they avoid drinking water, they get dehydration and oftentimes electrolyte imbalances, not to mention the nerves and the muscles don't work well when they're dehydrated. And that can lead to instability, cognitive impairment, and then higher risk of falling during toileting. So you can see the interactive relationship between the functional abilities. We cannot talk about one functional limitation in a silo because it's all connected with other ones. How about weakness due to malnutrition or not eating? In this picture, you can see my subject is standing there and set the walker to the side in order to reach a can of pop out of the refrigerator. This poses a fall risk, right? Because the walker is not useful when it's set off to the side. So difficulty with safe mobility causes them to avoid meal preparation and eating because it's hard to carry food items while having two hands on the walker. We can also have limited self-care or pressure injury or wound care, such as with hygiene. So for example, older adults report that bathing and showering is the most difficult ADL to perform due to slippery surfaces and the high energy demand. So then because it's so highly challenging, they often don't wash themselves. And if they don't wash themselves, their wounds or pressure injuries that they already had can get infected. And that was one of the reasons for hospital readmission is infections. Medication management, a lot of you wrote about this in your experiences. You probably have seen a lot of different types of literacy challenges. And this can also be influenced by cognitive impairment. A lot of people's cognition goes down in the hospital because different routines, different environment, all of those things impair cognitive performance. So then it makes it hard for those patients to plan, sequence, organize, and remember how to take their medication. So I would actually like to show this quick.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4, okay.
I would give her the 4 to 5, a tablespoon and a half.
One capsule.
That's right, one capsule?
One capsule. I don't know what this is. That's
Twice?
Twice daily.
Okay.
Okay.
So how would you take this?
When I see it's not on there telling you how to take it. It say take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was?
because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hypered? Hypered?
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
I don't know. That's what I consider it.
Okay.
It being,
Okay. But you know you have high blood pressure. Okay, but hypertension doesn't mean the same to you.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult to for me to take these pills because if they say one tablet twice daily, I don't know if they're talking take one in the morning, one in the evening, or take one in the afternoon or one in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body?
Of health literacy, where people may be able to read, but they may not understand the different types of terms used for health literacy, like hypertension versus high blood pressure. There's a lot of reading literacy challenges where it's hard to read the instructions on a pill container. And there's functional literacy where people can maybe read, but it's hard to convert the instructions into functional abilities. So here's another example I think a lot of you have witnessed. Typical scenario: patient lives alone with low income, can have difficulty with community mobility to shop for healthy food, which also is not affordable. We know that unhealthy food is more affordable because it's been processed down with little nutritional content. And also chronic disease management is affected because this person has limited access to blood sugar monitoring equipment and education due to transportation and financial barriers. These, as we all know, are socioeconomic or social risk factors such as socioeconomic status, living situation, home resources, and social support. Those are all reasons that people can get readmitted. So what are the solutions? Kirpalani and colleagues said that all the solutions really need to be multifaceted, including many strategies for planning, implementing, and monitoring interventions. We know there are programs to provide incentives to hospitals to prevent hospital readmissions, such as being financially penalized if there's high rates of readmissions. And we know there's more focus on certain conditions because of those programs, such as cardiac, respiratory, and hip and knee joint replacements. Now, this is an important study. This was a study done by Johns Hopkins Universities by Rogers, Levine, and Anderson in 2016. It was a very robust study. And this study is forming the foundation of this whole presentation. But I'm going to clarify the findings a little bit more by connecting it to the interprofessional team. So they studied thousands of hospitals and they looked at heart failure and pneumonia and acute myocardial infarctions and analyzed the data. And they looked at all the different spending categories for those particular patients with those diagnoses. And they found that occupational therapy was the only spending category that was associated with lower readmission rates because of the focus on functional abilities. Because of the focus on functional abilities. But I'm here to say that OT does not own functional abilities. I'm here to say clearly and strongly that it is the IP team that owns the functional abilities, and we can all work together as a team to target those functional abilities, because those functional abilities are really the crux of what is going to prevent hospital readmission. So the solutions: interprofessional promotion of performance in those functional abilities. People learn what they practice. People learn what they practice. From a motor learning standpoint, they learn what they practice, but it has to be the just right challenge. So we have to adapt those functional abilities or activities so that it's not too hard and it's not too easy. So what I propose is that the patients perform functional abilities while still in the hospital before discharge, with us being very transparent with our patients so that they understand the reasons for encouraging them to perform those functional tasks. And ongoing interprofessional evaluation of those functional abilities while in the hospital is really important. And a lot of you probably already are doing this. And so when we get to the collaboration parts of this presentation, I'm going to invite you to share some of your ideas. So what can we do in the hospital? Well, if toileting was such a problem with the poor mobility, and toileting difficulty causes dehydration, we need to help them be able to toilet themselves safely. And sometimes a raised toilet seat and rails may be all they need, but there's more. There would be more. And same thing with hygiene. If hygiene is such a difficult thing to help them be clean so they don't get infections, then we really can recommend a tub bench that goes over the edge of the chair. In this picture, you can see that he's sitting on the tub bench, but it's hanging over the edge of the tub so he doesn't have to reach back so far with his behind, and he can put his hand on the backrest. He can sit and then swing his legs over. If we have a tub and a tub bench in the hospital, we can practice this before the patient goes home. Then we have safe mobility. This is the fourth time mobility is threaded throughout this presentation. And I see Mary D. Danks is here. So Mary D., if you want to jump in, I'm happy to have you share your experiences. She's an expert in safe mobility. But it's important in the hospital to give them practice carrying items while using a walker. A lot of our older adults will be using a walker in the hospital. And we can adapt the walker with a tray table so that they can place items on that tray and transport items that they need and actually practice doing that in the hospital. In addition, it's good to have a reacher because we all drop things on the floor. I like to keep mine handy all the time. Matter of fact, I have one right here. I have them all over my house. But if they don't have to reach down to the floor, we can keep them safer, because that's where a lot of times people fall, is when they're reaching for things. And then we have them practice in their hospital room safe use of the walker and keeping the walker handles really close to the pelvis at all times, especially when turning or reaching for items. That can also promote safe mobility. And then it's important to ask the patient what are some of their resources for obtaining the adaptive equipment. So that reacher is not reimbursable by insurance, so they would have to pay $25 or $30 for that. But there are community resources that can provide this type of equipment for them. Same thing with the raised toilet seat and the shower bench. I check them out from advocacy organizations all the time for people that I know and work with. Then we also have the ability, functional ability for disease or condition or health management. So what are the special instructions that there will be at discharge? It's important to start having the patient follow through on those special instructions from the get-go in the hospital whenever possible. So for example, if somebody has lymphedema, it's important that they start being the manager of their elevating of their legs or getting those compression garments on and practicing applying compression garments, or maybe they've been taught to do some self-massage techniques or Epsom salts. Also wound care. Patients can practice the dressing changes with supervision from nursing or PT or OT, whoever from the team is directly responsible for those dressing changes, then they can provide the supervision, but have the patient actually do it. If the patient's going to be doing wound care at home, then the patient should be practicing in the hospital. If they have a family member who's a caregiver who's going to be doing those dressing changes, they really need to practice doing that in the hospital with the patient rather than after discharge, because doing something and hearing about something are two different things. It's easy to repeat. Sometimes it's hard, but it's easy to listen to. But when it comes to actually doing it, there are many variables that factor in that disrupt the ability to perform the wound care. Medication safety. This is a little bit of a stretch because of medication safety issues in the hospital. However, it might be worth considering supervised education and guidance to the patient or caregiver to actually practice their own medication routine with the actual supplies that they will be using at home. We could have the patient actually set timers for medications, so the patient is initiating the time to take the medication rather than a nurse coming in saying, oh, it's time for your medication. And then the patient can call the nurse when the timer goes off. And then the nurse can come in and actually have the patient take the pills out of the pill bottle, load them into a pill organizer, and provide that supervision and practice, or supervision for practice. I know time is an essence. I do know. I know it's hard, but whenever possible, if we can have a patient practice in the hospital, we potentially could reduce some of those hospital readmissions. And let's not underestimate the power of engagement in leisure activities. Who ever heard of doing leisure in the hospital? Well, it's done, and it's amazing what a difference it makes. So I have permission to share this, but I have a family member who was in the hospital and of course had electrolyte imbalance, which affected cognition, and had the robot sitter. Every time she tried to get up from bed, the robot said, please sit down. And it was very aggravating for her. So I went out and I bought her an adult coloring book. She'd never done adult coloring in her life. She started coloring, and it was amazing the difference that it made. It helped her with her attention span. It helped her focus. She made decisions. It helped her to sequence steps. All of these higher executive functioning skills, even though the electrolytes hadn't changed yet, her focusing and her executive functioning was improving even without the electrolyte changes. Very amazing. And so thereafter, she continued adult coloring, and now she started watercolor painting, and she's sharing this, and it really lifted her mood and decreased her agitation. So anybody can promote meaningful leisure. If you have a rec therapist, that's great. But any of us on the interprofessional team can help call a family member to bring in a meaningful leisure, but it does make a difference. Meal preparation. Do patients make meals in the hospital? Unheard of. Well, I've actually done it with patients in the hospital. I don't know if it was against the policies. It might have been, but I did it. So we can bring the patients into a kitchenette. Yes, are patients allowed in the kitchenette? Maybe not, but maybe they should be. I don't know. We'd have to talk to administration of the hospitals, but we can actually have the patients make a sandwich in the kitchenette, and that's a great chance for them to practice using safe walker placement while reaching for items. This is the same person. This time she's got the walker where the handles are right next to her pelvis, so she's in a stable position and she can reach down for that can of pop. And they can practice different ways to transport. We can put a tray table on this walker, or we can also give her a cafeteria tray or a cookie sheet to place on the kitchenette counter and place items on there from the refrigerator, and then slide that tray across the counter to transport the items. It happens when a patient is too sick to perform functional activities while in the hospital, but is supposed to be discharged. Need to delay discharge, I agree, and or find a suitable discharge plan that has support for functional activities after discharge, such as a skilled nursing facility or home health or TCU. I agree. If they're too sick today and we're planning to discharge tomorrow, we probably need to look at our discharge planning a little bit more in detail. Talk through what needs to be done. Absolutely. Walk through it, talk through it, demonstrate it. And then that whole issue of transparency, explaining the reasons that you're talking through this and encouraging participation. And then discharge planning should include, thank you, Nikki, community services and resources together to support. Absolutely. And we've got a whole list of resources coming up that we can add to. And Colleen said patient would benefit from TC or delayed discharge. Yes, I agree with that, all of those. And then the next question is, what if the patient does not want to perform functional activities? So that's happened as well. The patient says, hey, I'm in the hospital, my insurance, or I'm paying big bucks for care. I want you to do it for me. So a good approach, encourage them to show us what they can do so we know they will be safe at home. Yeah, give them the just right challenge or demonstrate that you're able to do it. Yep. Need good communication with patient to explain you're looking out for their safety. I love the good communication, and I like to use the word motivational interviewing. That's where we paraphrase, reflect, and probe with open-ended questions. And I never, ever, ever ask a why question. I never ask a why, because like Meredith says, we need to give reasons, the reasons why, without asking them why. So we give the reasons, but we can ask them what those barriers are. So thank you for sharing. And then work with the patient to define their goals and work with their worldview goals. Yes, absolutely. Goals come first. What are your goals? How do you think you're going to get to those goals? Let's talk about that. And you will actually go faster by going slowly to find out what their supports and their barriers are. We have interdisciplinary meetings, including the patient with all inpatients every morning. And these concerns are addressed daily and communicated what needs to happen in order to discharge. Beautiful. Open, transparent team meetings. Beautiful. Yes, I would agree with all of those. Okay. So let's talk about patient and caregiver education. So this is where those communication tools come in handy, and the suggestions that you all made are very important. So the patient and the caregiver education, there are words: compliance, adherence, and ability to follow through. Which is the most ethical? And ability to follow through or adherence? Ability to follow through or adherence. I would assert strongly that the word compliance is a bad word. The word compliance is a bad word because it suggests authority and an authoritarian rule of the healthcare provider over that. Well, it's the team's responsibility to identify those barriers, not the patient's, because the patient's sick. So we have to ask the patient, what are the barriers? And then collaborate with the patient to come up with strategies to overcome the barriers. And so Hill, from the PT literature, studied the barriers and supports. And basically, there are legitimate barriers and there are a lot of supports that can help a person. So paying attention to those through motivational interviewing, you can extract that information and then modify your recommendations as indicated. So with that said, I mentioned that transparency is so important. People need to know the reason in order to be motivated. So in the Hill study, motivation was a reason not to do something, and motivation was a reason to do something. So we have to be transparent and explain the reasons behind it. It's also important to pay attention to literacy and remember that reading literacy is different than functional literacy, which is different than health literacy. And that's different from health information technology types of literacy, such as navigating the patient portal systems or reading through all the noise on the discharge forms. There's a lot of irrelevant information that's on some of those documents that we get, and it's hard to find and sort through the noise to get to the relevant information. So patient caregiver education materials really need to be designed beautifully. They need to have pictures to represent the concepts. There needs to be a balance between images, white space, narrative text, bullet points, and it really should be written at a 6th grade reading level or lower with pictures to showcase that. So I want to find this one. This is a really good example of a good patient education material. This is put out by the Center for Disease Control. It's a home safety checklist to prevent falls. And as you can see, there's a balance between images, narrative, bullets, white space. You can see diversity among the images of people represented. There's some information about the reason to address falls, and then there's a predictable format. So you have an image. I'll show you another one. This is a good one. You can check the stairway. Is there a railing? If not, then these are the recommendations. And every page is the same. Here's a question. If the answer is no, then here's a recommendation. And look at how nicely it's balanced with the bullets and the images. Tub is not busy. It's plain clear. You can see the pictures of the rails. Have grab bars put in next to and inside the tub and next to the toilet. So the pictures represent the narrative. Showed in the last, in that checklist, some of the cultural considerations. So if your patient has, if there's a language barrier, then we're going to need to maybe use interpreters if they agree to the, there's privacy issues with that. We need to use images, demonstration, role modeling, role of the family. Some people want their family there, some people don't. And role practicing functional abilities. Some people, yes, I'm advocating for practicing, of course. However, there are some cultures where practicing is not a concept. They are about watching and learning and observing, and you don't do something until you're ready to do it perfectly. And so some of your patients may decline to practice. Well, if that's the case, that's okay. If it's part of their cultural inheritance, then it's okay. We can compensate by using videos, demonstration, and role model. Also, the CDC has a really nice document on reducing, a really good document about addressing health disparities. And then what about home evaluations prior to and during discharge? Has anybody ever done a home eval before discharge? Well, they say there's a financial strain and a productivity barrier, but I'm here to say that it's probably more expensive to not do home evals. And I have done home evals prior to discharge. I have gone home with patients while they're still considered inpatient. So maybe we can't afford not to do that. So the scenario, I don't have time to tell you about the scenario, but I'll just let you know. I almost didn't do the home eval because I knew she was really good where we were at. But I thought, no, I better go check anyway. If I hadn't done the home eval, I know she would have ended up back in the hospital by Monday, because she went back to her old habits once she got in her home. So, and then the other thing is there a reason why an IEP team member can't go home with a patient during discharge? And once they get in the homes, just see how they do getting around the house. Are there tripping hazards? Can they get on and off the couch? I mean, we bring them up to the door and then we help them into the car and then we stop. There must be a way that somebody could actually go home with that person. So now to the community resources, what are in the services? Here are some of the services. We've got the transitional care units in nursing homes, rehab centers. Absolutely. If they're not ready to go home, then let's look at an alternative placement for a while. I like home health nursing for medication management, meal preparation, disease management, hygiene, etc., especially right away. And then you have an ongoing evaluation, make sure that they can do everything, and then you can gradually decrease the home health nursing as the person gets more acclimated to being home with that condition or gets better. And pharmacists, according to Bingham 2019, they really are a great IP team member and a leader for medication safety and education. We can do OT-PT for ADL, IADL, speech language pathology for communication. Oh, I forgot to go back to PT for that functional mobility. Everybody should be working on that. But now this is the 5th time this one has come up. So it's really an important area. Communication, can they make their needs known? Can they access services and help when they need to? Can they communicate? Social work to help access the services and navigate those health systems. Social work is a great key player in follow-up, and same as physicians. Patients often have a high regard for physicians' instructions. So if the physician says so, then it must be so. And then here are a lot of the different community resources that I really, really like. If they need a raised toilet seat, let's call the North Dakota Association for the Disabled. I don't know the name of the advocacy organizations down in New Orleans, but I'm hoping that some of these advocacy organizations are nationwide. So what are the community resources available? The service providers for seniors has a list of all kinds of services, and those are often distributed at the Senior Citizen Center. YMCA has senior exercise programs, and then follow-up visits with the social worker are so important. There's just so many things the whole team can do. Those follow-up visits can be done by any of the team members. So you get to pick who you think would be the best one. There are analytics that identify low, medium, and high risk for readmission. So a medium risk would have that discharge planning plus a telehealth follow-up. A high risk would be discharge education, 2 appointments for the primary care physician, and telehealth follow-up, and care experiences and your ideas. How would you address falls, risk of falls, dehydration, and such as difficulty with toileting safely, which causes the patient to avoid drinking water, and electrolyte imbalance. Do more evaluation, Nikki says, to where the issues are, problem solve from there. Absolutely. What other solutions are there? Anybody want to type in? What other resources might be helpful?
So we have a comment that says PT, OT for strengthening.
Yes, absolutely. PT is to assist with ADLs. Yes, I'm an advocate of those private caregivers. Absolutely. Use more staff. Focus on prerequisite needs needs to make the function better. Yep, what are the prerequisites? Safe mobility causes them to avoid meal prep. Create daily log for drink food intake. Yes, a daily log, a checklist that includes time and amount. Add rewards. Yes, some people do respond from behaviorism. Add rewards when meeting goals. I love Meals on Wheels. I recommend Meals on Wheels to everybody because I know they're getting at least one meal a day, Monday through Friday, and they're still exercising and practicing for breakfast and supper and weekends. So I do recommend Meals on Wheels. And private caregiver, PCA or nurse aid services, if qualified to help with meal prep, absolutely. And problem solving on kitchen setup and safe mobility. That's my favorite thing to do, is actually do the kitchen mobility and teach them how to cook. And I'm bringing a nutritionist too. If somebody, I think about the gentleman whose wife cooked all these years and now for whatever reason, she's not home with him to cook anymore. And now he has to manage his diabetes and he doesn't know how to cook and doesn't know what to cook. That'd be really helpful for an interprofessional team between especially PT, OT, and the nutritionist to make healthy meals. Variety, so bathing, showering is the most difficult ADL to perform. What else can we do? We mentioned the tub bench and sitting down first and then swinging legs over. We mentioned the rails. We mentioned, so there's sitting, there's caregiver assist, OTPT, absolutely. We need a no slip mat on the bottom. We need a low profile absorbent rug that's not going to get, they're not going to trip over to absorb any water. Even knowing where to put the shower curtain and how to keep the water in the tub while using that weird tub bench is a trick. Private caregiver assistance. Yep. Even showing a family caregiver how to do it safely. And then accessing those advocacy organizations that have equipment loan programs. Exactly. Okay. So the medication management, what else can we do for medication management? This one is at least 50% of, we've seen about 50% of you saw that medication manages. And we can't just pick one old pill box, can we? It has to be one that the person can manipulate with their hand dexterity. It has to be one that has the right amount of pills. The ones I use are 2 morning and night, but some people need to take pills 3 or 4 times a day. So we might have to have times, but then the more pill containers you get, the smaller the writing gets and the smaller the lids get. Medication reconciliation, absolutely. Absolutely. Knowing how to reconcile that medication, how to use checklists. What's
has used these and they're pre-packaged what medicine takes in the morning, what's at noon, what's at evening, what's at night. So they just have to punch the little back and their pills are there for them. So there's no opening pills or deciding. It's set up, and then you can see if they took them, the bubble pack or the blister pack was opened, and you pay a little extra, but I have to say it's just a lifesaver when they package them like that.
So it worked really well for your mother.
Yep, and when she got caregivers, it works really well for the caregivers. They don't have to mess with the medicine at all. It's predetermined what they get.
Yeah, and if you think about it, it might cost a little more, but it might actually save on labor time and billing for somebody else to prepackage things in a pill container for them.
And guaranteed that they took them in, and you don't have to have a pill pack that's 4 deep for the day because it's made, and we'd get them by the month, so you get 4 packs for the month. So they worked really well.
Yep. And I like the pharmacy consult too. Thank you, Colleen, for adding that in. that medication reconciliation is coming up again, and there's so many different systems by which to do that. And then have the patient bring all meds into the clinic for the reconciliation, or can we send a nurse out there for reconciliation? It depends on the ability to use transportation. So yes, I like that. And there are pharmacies that do it for free. There are electronic pill minders. By the way, the North Dakota Association for the Disabled had a really nice electronic pill minder device, and it was big and it was timed and it distributed the meds only at that time. It was pretty neat locking device. Yes. And those you can get from NDAD. And if you're from another state, you can check with your state organizations to see if they have loan programs or checkout programs or rental programs for things like that. And same with the pharmacy. Must check meds each shipment. Sometimes not all are included or meds are changed. Yes, it's hard to keep track of those changes, isn't it? And there are phone apps that can be used for reminders if it's someone who can use a smartphone. Thank you. Thank you, Anne, for adding that. Okay, great ideas. This is what I wanted. I wanted the interprofessional collaboration. So the title of this is IP collaboration, and we're doing IP collaboration. So